Okay, thank you, Professor Jiang. Dear Shen and dear Hurwitz, my name is Zuo Song, and I come from National Clinical Research Center for Cardiovascular Disease, Beijing Anzhen Hospital, Capital Medical University, Beijing. And it's my great honor to take part in this seminar and introduce my study. Today, my topic is ethanol infusion in the vein of Marshall on acute reconnection after a mitral isthmus block. I will introduce my study from these four aspects. The first part is the background. As we know, the vein of Marshall is also known as left atrial oblique vein, and it's first described by John Marshall in 1850. And look at the right picture. The right arrow indicates the vein of Marshall for the first time. And the vein of Marshall is the remnant lacunar structures of the ligament of Marshall, where the ligament of Marshall is the embryonic remnant of the left superior vena cava. And the vein of Marshall together with Marshall bundle and the autonomic nerves constitute ligament of Marshall. And the reason why I pay attention to the ligament of Marshall is that because there are several branches are inserted into left atrium, pulmonary vein, and atrial appendage. The first picture shows the location of vein of Marshall and his neighboring structures, and the other two pictures show the connections, which consist of small muscle bundles under the microscope. And Professor David has reported distribution of vein in the left atrium in 2017 in JACC-EP, and he classified the vein in the left atrium into 8 veins. They are septal vein, inferior vein, vein of Marshall, appendage vein, anterior vein, and posterior veins, and roof vein. The last one is the extracardiac veins. From this table, we can see that the vein of Marshall has the highest presence of 92%, and the second one is the appendage vein, has the about 52% of the presence. And Professor Thomas in Bordeaux, France, has reported the distribution of mitral isthmus conduction recovery in 2006, and they divided the mitral isthmus region into quarters and found that the middle and upper segment has occupied nearly 86% of the recovery site. It suggests that the distribution of mitral isthmus conduction recovery is consistent with the cause of ligament of Marshall. This is our center's previous RCT study in 2015. 146 patients with persistent AF were randomly assigned to the 2C3L group, which include CPVI, roof line, mitral isthmus line, and the CTI line, and compared to stepwise group. And the general rate of mitral isthmus block was about 86%. And after 25 months of follow-up, 24 cases performed the redo procedure in the 2C3L group, and the general mitral isthmus recovery rate was about 75%. And the second finding of our study is that the perimetral atrial tachycardia, PMAT, account for more than 50% of the recurrent forms in both groups. From this table, we can see that the mitral isthmus dependent account for 55% in the 2C3L group and 53% in the stepwise group. It suggests that the vein of Marshall may have played an important role as an epicardial pathway. Accumulated evidence has demonstrated that the EIVOM has been shown to effectively destroy the epicardial connection related to the vein of Marshall. However, its effect on acute reconnection of mitral isthmus block is yet to be validated by strong evidence. Look at the red pictures. After we finish the mitral isthmus line and pace at the left atrial appendage site, we can see that from the two bits, we can find that the mitral isthmus line has been blocked, but the other two beats, we can find that the mitral isthmus block has been recovered. So in our study, we trying to investigate the effect of EIVOM on acute reconnection after mitral isthmus bidirectional block. The method. Our study is a randomized clinical trial with a single center. The patients who were eligible for this study were randomly assigned to the either RFC group or EIVM group using a randomization chart. In the RFC group, we take 2C3L strategy. It includes CPVI, roof line, the mitral isthmus line, and the CTI line. If necessary, we will give CES ablation. And in the EIVOM group, we perform the EIVOM first, then we give a 2C3L strategy for ablation of the first is and the patient undergoing their first AF ablation procedure and symptomatic persist AF with history the refractory to at least one class 1, 2 of AD. And fifth one is willingness and commitment to take part in our study. We set the main endpoint and the secondary endpoint. The main endpoint is acute reconnection of mitral isthmus directional block after 30 minutes observation. And we set secondary endpoints are followed. First of all, mitral isthmus bidirectional block at the end of the procedure. 2 is the first pass block on mitral isthmus block. 3 is the location of mitral isthmus reconnection gap. 4 mitral isthmus ablation time. 5 is the total procedure time. 6 is the reconnection 30 minutes after PVI. 7 is the ablation time for the left pulmonary vein and the right pulmonary vein. The 8 is the complications related to EIVOM. The last one is the AF rate after the follow-up period. Here is our study's flowchart. We first randomly assigned a patient with persistent AF who was scheduled to receive ablation for the first time to EIVOM group or RFC group. Then we performed the procedure as planned. Then we observed 30 minutes. And after the observation, we checked the mitral isthmus bidirectional block. Then we complete the procedure. Here's the EIVOM procedure. We use the EIVOM approach as previously reported. The RFCA procedure. We perform the 2C3L strategy. The details of the RFCA procedure has been previously described. In brief, a highly density mapping catheter, pantry, and STSF ablation catheter was used in our study. The power in the left atrium was set to 40 to 50 watts, and the power in the CS was set to 25 watts. During ablation, the average contact force was kept at 10 to 20 grams, with the inner lesion distance of ablation was 3 millimeters. Bilateral PVI was performed, followed by a roof line, mitral isthmus line, and the CTI line. If necessary, the CS will be also ablated. In fact, we performed the intra-CS ablation in all the patients. And the last point is the ablation index. The validation of procedure endpoints. The mitral isthmus bidirectional block is confirmed in both groups by the following characteristics. The first point is proximal to distal CF activation pattern with pacing as the left atrial appendage or left lateral ridge. The second point is the activation from the left atrium lateral wall to the mitral isthmus line when pacing as the distal CF, or as the interval as the left atrial appendage is longer when pacing as the CS distal than CS proximal. And the study and the patients will follow up at 3, 6, and 12 months after procedure. During the follow-up, 12 lead ECG baseline and 24-hour Holter ECG monitoring was performed. Recurrence were defined it as any document atrial tachyarrhythmia, including AF, AT, and atrial flutter, sustained for about 30 seconds after a 3-month blank period. If patient experienced symptomatic and or ECG documented atrial tachyarrhythmias, they will offer a repeat procedure. And the third part is study results. A total of 89 patients with persistent AF were enrolled and were randomly assigned to the EIVOM group, which include 45 patients, or the RFCA group, which include 44 patients. From this baseline table, we can find that there were no statistically difference in the age, gender, history of AF, hypertension, diabetes, stroke, TIA, coronary heart disease, congestive heart failure, peripheral vascular disease, left atrial diameter, or EF value. Here we show the effects of EIVOM on voltage mapping before and after EIVOM procedure. And the EIVOM parameter EIVOM due to a lack of vein of Marshall or small size of vein of Marshall. In the EIVOM average procedure time was about 20 minutes, and the total extreme export time was 250 seconds. The procedure parameters. The total procedure time in EIVOM is shortened than that in RSDA group, mainly because of the shortened in ablation time for mitral isthmus and left pulmonary vein. The initial mitral isthmus block were 84% and 100% respectively. Notably, the rate of the first pass block rate on mitral isthmus was 63% in EIVOM group and 23% in the RSDA group. After 30 minutes observation, acute reconnection occurred in 3 cases, about 6.7%, and 13 cases, about 35% in the EIVOM or RSDA group respectively. The final bidirectional block rate of mitral isthmus was 97.8% in the EIVOM group and 72% in the RFCA group respectively. There was no reconnection of pulmonary vein isolation in the EIVOM group, but 3 cases occurred in the RFCA group, with all gaps located at the ridge between left superior pulmonary vein and the left atrial appendage. And the recovery gap distribution. We divided mitral isthmus into 4 regions based on its anatomical feature and the position of the balloon during the procedure of EIVOM. The upper region was defined by the reconnection, by the connection line between the left inferior pulmonary vein and the left atrial appendage. The middle and the lower region were divided by the position of the balloon during EIVOM, differentiated by whether the ethanol worked. CS alone constitutes the 4th region of the recovery gap. From the red pictures, we can see that in the case that receive RFCA only, the recovery gap were mainly observed in the upper, about 46%, and the middle region, about 30% of mitral isthmus. By contrast, the reconnection in the EIVOM group all located intra-CS about 67%, or lower region about 33%. The procedure safety. Neither group happened any severe safety events during the procedure. In 41 patients who received EIVOM, no complications such as vein of Marshall ruptures or ethanol slippage occurred, and contrast retention can be seen in the distal region of the vein of Marshall. 2 patients in EIVOM group and 1 patient in the RFCA group had pericardial effusion, but no further treatment was required. And our study had 1 year follow-up. After a 3-month blank period, 8 and 14 patients in the EIVOM group and the FCA group experienced recurrent AF respectively. So far, 4 and 8 patients in the EIVOM and RFCA groups have the repeat procedure. Notably, mitral isthmus reconnection happened in one patient about 25% in EIVOM group at the CS region, and 4 patients about 50% in the RFCA group at the upper and middle region. The clinical implication. Our results reveal that the EIVOM can reduce acute reconnection after mitral isthmus block and improve the efficiency and the durability of mitral isthmus bidirectional block. And our study also demonstrates that the EIVOM has the potential to play an effective and powerful role as an auxiliary strategy in the catheter ablation of persistent AF. Here is our center's ongoing RCT study about the the comparison between an updated 2C3L versus a PVI approach for catheter ablation for persistent AF. This study the 2C3 to PVI after 1 year's follow-up. And this study has completed all enrollments in July 2023. And we estimate we will finish the follow-up the next year. And the result of this study may provide a powerful approach to improve the outcome among the patients with persistent AF who are going to receive catheter ablation. And here's my introduction